indicated, and what is their outcome
Okay.
compared to radiotherapy or
Sure.
chemotherapy?
So I think on Thursday I'm going to give you a talk about HER2 positive breast cancer. So say for example HER2 positive breast cancer. So use a monoclonal antibody called trastuzumab to treat these patients, and uh, you, there have been studies in both in the palliative setting and in the adjuvant setting, and both of them have been found to be to improve progression-free survival and disease-free survival. Say in the adjuvant setting, if you use somebody's got HER2 positive breast cancer and you use after chemotherapy you use Herceptin, it reduces the risk of recurrence by about 50%, so hazard ratio of about 0.5 or something, and it's made such a difference to in the management of HER2 positive breast cancer, and especially in the metastatic disease. Today, if you have somebody with stage 4 HER2 positive metastatic breast cancer, the median survival is about 56 months. That's almost 5 years. That means 50% of your patients will survive for 5 years. And this is on a scale which you never saw before anti-HER2 directed treatment. And all this came about in the mid-90s, where they identified that these patients have an aggressive clinical phenotype, but there was no treatment available. And then when anti-HER2 directed treatment came in, they found a significant difference. I mean, the impact was as much as having tamoxifen for breast cancer in the adjuvant setting. It was quite significant.
Thank you, sir.
Sir, when you use concurrent method of therapy, it could be possible that sometimes the disease it doesn't show any response, but the time period, say, that radiotherapy would take would be, the time period that chemotherapy would take would be different to that of radiotherapy. So how do you assess whether your therapy is working when you're using a concurrent approach?
You're right. When the difference is when you use concurrent chemotherapy, the dose of the drug you use is not as high as when you use chemotherapy on its own, because the mainstay of the treatment is radiotherapy. Chemotherapy is given to potentiate or sensitize the cells. So I think Dr. Dutt talked about the cell cycle.
Yes.
So the most sensitive phase of the cell cycle is the G2M phase. All right? So what it does is it brings the cells into that specific phase so that it makes us more sensitive to radiation.
Right.
Okay? So it's very difficult to assess response whilst on treatment. Obviously, you see the patient every week, and if the cancer is growing, you know it's not working. But these sort of treatments take time to work. So the full effect of radiotherapy, to see the full effect of radiotherapy, you just have to wait for at least 4 to 6 weeks, even after on completion of radiotherapy. So you don't stop treatment unless there's obvious growth of the tumor.
Okay. So
Okay.
you continue the chemotherapy for 4 to 6 weeks?
No, say for example, when you talk about chemo radiation,
Yeah.
you give the chemo. There are various schedules, but you start the chemotherapy and the radiotherapy together.
Okay.
Okay, so day 1, day 21, day 42,
Right.
that way. Or you can do weekly.
Okay. Thank you.
So, okay, so I'll give you an example. Uh, so when you're talking about, say, I'll give you an example in the adjuvant setting, what we commonly use. Okay, so basically, when a patient has got localized disease, you're looking at curative intent. Okay, now the challenge is in terms of overall survival is when you talk about adjuvant treatment. Say, for example, a patient's got breast cancer. Patients had wide local excision, node negative. Patient has radiotherapy because patient has breast conserving surgery. Then you have to see whether you would like to offer this patient. You have to decide who you're going to offer adjuvant chemotherapy to, who's at more risk of recurrence. So we use some algorithms here, like there's an algorithm called Predict, where you put in, these are all population-based algorithms, but you put an individual data, say a patient is age 50, screen detected, node negative, hormone receptor positive, HER2 negative, node negative, and then you say, okay, if I have to give this patient chemotherapy, how much does this patient benefit from chemotherapy? So what we used in the clinical situation is anybody who's got a 3% survival benefit at 10 years, we discuss chemotherapy with them. Okay, that means of the 100 patients who are going to have treatment, only 3 of them are going to benefit, And that is the threshold as a starting point we use. Some might say, look, I don't want it unless it's at 10%. So that is the sort of level. So everyone has a certain threshold but usually in clinic, that's the threshold we start talking to patients about adjuvant treatment, because these treatments can be quite toxic.
Thank you, sir.
Hello. Good morning, sir. So does neoadjuvant treatment affect the patient compliance? Because what we see in our setups, the patient get relief of symptoms most of the time, and they didn't come afterwards.
Correct. So it's a very good question. And I think you have to be very clear as to what you're trying to achieve here. And you have to specify, if you're doing it before surgery, that is the definitive treatment. And sometimes patients, you're right, patients start on treatment and have good response. The tumor shrinks away. They say, okay, we don't want this surgery. But you've got to be very clear that. And in the Western cohort of patients, we don't see it. But here, I think there's a tendency that you might lose your patient.
Yes, sir.
Patient feels a little better with treatment and doesn't turn up for the definitive treatment. Yeah.
Okay. Vinod, there's a question over here.
Yeah.
Sir, as you said, palliative care is when you're trying to alleviate the symptoms as well as delay the death. I was reading recently that the scenario in the US is such that there is a very strong emphasis on aggressively trying to delay the patient's death. And we're not as sensitive towards, the suffering we are inducing on the patient thanks to all the drugs he's receiving. So can you tell us a little bit about your experience with palliative care in the UK and if it's any different?
Yeah, so we've been actually very fortunate to have very close links with the palliative care team. And we, usually before we refer patients on to the palliative care team, we seek permission of the patient whether they'd like to see them. And because, palliative care sometimes can have a very different connotation. Patients may be actively treated with chemotherapy drugs, and they feel that once you're referred to palliative care, they may not receive active treatment. So we always need to explain to them that, look, this is purely for symptom control, but we'll continue with the treatment. And so you always, you always have an honest conversation with the patient. Say if you've decided that this patient's not going to respond to chemotherapy, and you've decided to stop anti-cancer directed treatment, then you always get the palliative care team involved quite earlier on in the disease. Don't wait till the end, because patients' manifestation of disease may not just be physical, it may be emotional and psychological, and that needs to be addressed as well. So get them involved earlier on in the process, but always seek permission of the patient.
Hello, sir. So you said about we check CT scan response to treatment after 2 months. Why 2 months? Is there any specific reason?
No, usually you say it's at least 3 months, because you need enough time to see the shrinkage. So
is it same for all the cancers?
it's variable, depends. So sometimes you have a patient, say for example, with an indolent breast cancer who's got metastatic disease and has been on hormone treatment for, say, a couple of years. You don't need to repeat scans every 3 months. And the validity of a scan only lasts for that short duration of time. So you can, as per clinical need, you can extend it to 6 months. Sometimes patients, we are doing scans every yearly.
So what if we do scan, you told about lung cancer, done scan after 3 months.
Yeah.
What if we do in first month?
You have to give enough time for the cancer to shrink to see the radiological evidence that the cancer treatment is working. Because if you scan too soon and you find that there's not much of change, what are you going to do? Say, are you going to change your treatment? But you've not given enough time for the treatment to work, isn't it?
Sir, then what about 4 or 5th month?
So, okay, the thing is that rule of thumb is, it's not hard and fast, but generally you like to give 3 or 4 cycles of chemotherapy before assessing response to treatment. And say if somebody's having 6 cycles of chemotherapy, you'd like a scan at the midpoint, which is why I said,
3 months.
Yeah.
Okay, thank you.
We've seen that post neoadjuvant radiotherapy, like in GI malignancies, colorectal cancer, so it becomes very difficult to operate the patient after neoadjuvant radiotherapy. There are chances of complications also. So what is the role of stereotactic radiotherapy in such cases? Or should we prefer chemotherapy rather than preferring radiotherapy instead?
So there are quite at least 2 or 3 questions you asked there. So essentially, I'm not a colorectal doctor, but essentially, when you talk about giving neoadjuvant chemoradiation for patients with rectal cancer, that is 5 weeks of treatment. Debs, you can, help me here.
It might actually be, we've got a colorectal NDT,
Yeah,
so it may be better to ask, because
Yeah.
what you'll have with the NDT is the entire expert team down the front.
Yeah.
So that might be the better time to ask that
Yeah.
question.
And
Rather
there's
than
an
getting
op- there's an
the
optimal
prostate
time
breast cancer
for-
doctors to answer it.
There's an optimal time for surgery, 6 to 8 weeks after but I'm sure the specialty doctors can do that.
Thanks, Vinod. So next we've got Annie coming up
Sir.
on the stage.
Excuse me, sir. Sir, one moment.
Great. It's great to see you're all awake. I think there were lots more questions, so I think if it's okay, Simon, if we do have a bit of time, because I don't want you to feel left out and feel cheated. I think there were quite a few. That corner was being ignored, so they need a bit more time.
That was your corner, wasn't it?
That was my corner, I know, exactly. Well, what can I say? Thank you very much, Simon. Thanks to Tata Trust and for inviting me. I'm the new boy on this tour, and I have to say I'm thinking of getting a contract with the Indian Tourism Board